Everybody, I am going to start the afternoon session. So I love it when some of our presenters who I know could fill a book with their bio give me 2 lines and think that that's adequate. Dr. Elisabeth Fowley-Mock has presented off and on over the years to the Maine Nurse Practitioner Association, and she's incredible and has been on the cutting edge of evidence-based medicine in multiple arenas. And so that's the only little blurb I'm going to give, other than the 2 little tiny sentences she gave me. But I want you all to know how wonderful Dr. Mock is. And we're very, very grateful that she agreed to come today. So Dr. Mock is from Bangor, attended Colby College, Emory University, Vanderbilt University School of Medicine, and UNC Chapel Hill School of Public Health. She is board certified in family medicine and addiction medicine and works primarily as a consultant and clinical educator with per diem hospitalist shifts. Her passions are her family and 3 dogs, travel, women's basketball, and public speaking. And without further ado, Dr. Mock.
Thank you. So I'll need to follow up on the bio. There's 2 important things there. Today happens to be National Doodle Dog Day, and I have 3 doodles. So all of my coworkers at my consulting job got pictures of all 3 of them, but not for you. I'm sorry. They're on my phone. And then the second thing is women's basketball. WNBA preseason starts this weekend, and they're televising the preseason games because the growth of women's basketball has just been astronomical. But now we need to talk about science. So I'm here with the Maine Clinical Information, I said it wrong, the Maine Independent Clinical Information Service, and we go by the acronym MICIS, like Mickey Mouse. And we've been around for many, many years. We do a lot of grand rounds type talks and conference talks, which, by the way, thank you for inviting me, because now that I'm here, I remember why I love the Elisabeth so much. And I walked at lunchtime, even though it was windy, and oh, it's so beautiful. I'm like, oh, I need to come back here again soon. And we also do a thing called academic detailing, which is a one-on-one conversation. And so we have credit for that too, but I think people don't know about that. They come to grand rounds, they come to conferences, but they don't know we do one-on-one detailing. So right now we have 2 opioid related topics that are on our website, but we're retiring this topic as a one-on-one topic. Program of the Maine Medical Association, our funding comes from the Office of Maine Care Services, so through the state. And we practiced this before. And we do it in the right direction. Well, there's always the keyboard. There we go. So today we're talking about GLP-1s and SLGT-2s, and you already heard about me, so I can go right to the next slide. Disclosures, there's no money from pharmaceutical companies. This is independent content, and I have no conflicts of interest except to say that I work as a contractor, and so I have multiple different contracts. So to be really clear, I'm here today as a contractor with the Maine Medical Association talking about this, and not any of my other contracts. And there is one slide where I go into off-label use a little bit, the kind of crisscrossing of different GLP-1s that are the same drug but different brands. So when I get there, I'll try to remember to say, and some people do this off-label, but in case I don't, that's your off-label disclosure. And we're going to talk a little bit about the guidelines that recommend our drug selection in type 2 diabetes. We're going to talk a lot about pharmacology. So I know that there was a pharmacology question when I filled out the paperwork. There's a lot of pharmacology here. So hopefully I put the 45 or 60 minutes of this talk as pharmacology, because it mostly is. And then we'll talk a little bit about comprehensive diabetes care, just to remind us of all those other things that we need to talk about with patients with diabetes. And someone might ask, but I don't see weight loss and treatment of obesity in your objectives. And that's because when we started this module, which is about to retire, it was really focused on diabetes. But what I tell people is, and then over the 2 years, people are like, weight loss, obesity. It's the same drug, GLP-1s. So we're going to talk about mechanism. We're going to talk about side effects. We're going to talk about some strategies. And so it's the same no matter which indication you're using it for. So So there will be a little bit of it, but we're supposed to be primarily focused on diabetes. So really quick talking about pre-diabetes, and this is something everyone already knows in terms of lifestyle management for pre-diabetes, talking about both diet, nutrition, exercise, and then thinking about things that we can do to help our patients who are in that in-between stage with that A1C that's not quite at the diagnostic level, but still above average. And so there are some diabetes prevention programs. There's one at the Bangor Y, which is pretty robust, but that isn't everywhere in the state of Maine. And then, exercise. I was telling someone earlier, I just can't make myself exercise. So I totally get that with my patients. Like, I can't do it unless I have a goal. So I'll say out loud in public, my goal is that I am going to at least, we're not supposed to use the word try. She said this morning, I'm going to practice. I am going to practice climbing Mount Katahdin this year. And so I've got to practice a lot before I even get there and climb a whole bunch of other and go to the gym and work out. And so there I'm making my thing out loud. So because I've set that goal for myself, then I will actually exercise. But other than that, I struggle like a lot of other people. And I like this, any activity is better than none. So 2 years ago, I got myself a stand-up desk because now that I do consulting, I'm not going from exam room to exam room. And I got one of those little foot bicycle things to put under my desk. So any activity is better than none. And I don't have the reference here. Hopefully I have it at the end, the reference to the study. But I thought it was an interesting study that looked for people who progressed from pre-diabetes to diabetes. And on the left is the people who are younger ages, and on the middle is the people who are the middle ages, and it's 45 to 59 years. And then on the far side is people who are a little bit more senior, 60 and older. And they looked at 3 different interventions or lack of intervention, and one is placebo. So people who are randomized to do nothing, they progressed to diabetes in that blue bar at higher rates than people who had an active intervention. The people who were randomized to metformin in the red bar, you can see that the younger people, the metformin was more effective in preventing that progression. But as people went across the age spectrum, that drug treatment wasn't as effective. And on the flip side, the green bar, lifestyle management, was more effective for the people who are older, which might be even harder for us to learn new habits as we get older. So I thought that was an interesting finding, that at different ages, different things. So someone who is older, 60, and I don't consider that much older now like I used to do, but someone who's in that 60 plus frame, there's really potential benefit for some lifestyle modifications for them, even though they say, no, it's too late. It's just like someone who has COPD and who quits smoking, they change their curve. It's never too late to stop smoking, no matter where you are on your COPD trajectory, that you definitely change the curve, even by quitting smoking when you're having pretty severe COPD. So it's never too late. And then just a quick reminder of what are the ways we diagnose diabetes. We do this all the time. We've really grown to count on the A1C, and that is one way, but we also have this fasting plasma glucose greater than 126. So I work as a hospitalist. How many of my patients come in with a fasting plasma glucose greater than 126? Because they're all sick and under stress and having an MI. And so what that does for me, and my hospital says over 104 is abnormal, but this says 126. All that does to me is say, oh, I need to order an A1C for these people tomorrow morning. And then I look at the A1C, because at least a good bit of the time it's a stress response, but a good bit of the time it's, has anyone ever told you had high sugar? And the patient says no, and the next morning their A1C comes back at 8. And you not only diagnose their MI, you also diagnose their diabetes. So I do that as a follow-up. And then the random over 200 and classic symptoms. I like how they put that in there. So yes, that would work, because I once in a blue moon, I'll see someone over 200 who has a normal A1C. So you have to kind of understand the context. So I think that's all I want to say about pre-diabetes. We threw that in there, but really we want to talk about people who have diabetes. And I picked a relatively nice name, depending on what you think, for the state of Maine, Angus. There's a doctor who he's worked in Bangor and he's worked at Penn Bay. His name is Angus too. So our patient Angus is a 45-year-old who was recently diagnosed with type 2 diabetes, so younger age spectrum. He works as a local delivery truck driver, but not for UPS, which is good because apparently they cut a bunch of people. And he lives in this idyllic place called Crabapple Cove. And so what are some of the things that we might think about for Angus? And what do we think about his A1C goals? So kind of think to yourself, where do we want to go first with this guy? He's younger, he's 45, and what else do we need to know? So the first thing is to think about individualizing goals. And so he's younger and pretty recently diagnosed, so he's going to go in that tight control group, definitely less than 7, but maybe even lower, like 6.5. I see all the time patients who are like 82 who are on insulin 1 to 4 times a day with an A1C of 7, and I'm like, this is wrong. We need to stop doing so much insulin. You're okay if your hemoglobin A1C is 8, or maybe even 8.3 if you're 82 and you've been hospitalized twice in the past year and you have a lot of medical comorbidities. So back when I started a long time ago, everyone had to be under 7, and that was the thing. And now that's different, so have to do a little frame shift. And I'm going to talk about what are the things that make us think about who needs what. But for Angus, he's young, recently diagnosed, young, 45. So he's closer to the less than 7, less than 6.5 end. So these are the types of things that we would think about in terms of who needs to be tightly controlled. And so at the short end of the wedge is more stringent control, and those are the things in the column above it. And at the high end of the wedge, to go along with a higher A1C, is less stringent control. So you have to think about the risk of hypoglycemia. And I have 2 slides about hypoglycemia at the end. How long have they had the disease? And some of these are not intuitive. Long life expectancy, short life expectancy, that's pretty intuitive. Major comorbidities, severe comorbidities, this is where I started thinking it's not intuitive. Absent vascular complications, severe. So I have a patient come in and they are in for vascular surgery and they're having a hind foot amputation or a below the knee amputation because of vascular complications, and they have pretty severe diabetes. And everyone always says you really need to control their diabetes. Well, actually, that horse is long since left the barn, and trying to strictly control them can actually give them more problems. But that's like hard to wrap my head around. I want to tightly control someone who already has end-stage disease. But this is not what the newer guidelines treat me. It is also patient-centered and up to the patient, kind of how they want to set their own goals. And then also access to resources, but we have to be careful when we think about equity, because we want to make sure that we can give everyone who needs them accesses or help align them with accesses to resources, because we know that not everyone has the same access. The next page here, you can't read it here. I just want to tell you it exists. So you look at it for 2 seconds, can't read it. It is in the American Diabetes Association guidelines, and it says what I said on that last slide. I retyped it, but with a wedge for each of those things. And there's an app for that. It's the American Diabetes Clinical Practice Guidelines. I think it says SOC, like Standards of Care. And it's a really nice app, and it has all of the current up-to-date recommendations. So if we're thinking about the patient, obviously we're thinking about our 2 goals are to prevent complications, but also to have decent quality of life. So for some people, they don't want to take insulin shots 4 times a day. For some people, they want to be on a continuous glucose monitor and have all that stuff, and they maybe, according to the evidence, don't need it, but they still want it. So trying to figure out where each person is at. And there's a big figure that I had in the slides, but again, it's one of those things that it has 800 words on it and it just doesn't work on a slide. So it's at the end of the deck if anyone wants to see this figure. I'm having trouble even with the mouse. Let's see if this works now for some reason. Ha! Look at that. So just thinking about shared decision making, and that's something that maybe 20 years ago I didn't always think about, because we didn't talk about patient-centered care and shared decision making. It was sort of still much more provider driven and telling people what to do instead of asking them what their goals are and what they want. So this is kind of the new way of thinking about every disease. So I always like to put in a list of the medicines because when I'm thinking about a particular topic, I can't always keep them at the top of my mind. And so I like to think about classes and then the individual medications. And we have the generic, of course, because at MICIS we only speak in generics. But just so you know what we're talking about, there's the brand name right next to it, so you know what it is. And there's still a role for metformin that we'll see in the algorithm, so I had to keep that in there. And then I don't know why the people who made this list, I was lazy and didn't retype it. They put SGLT-2s before GLP-1s, but it seems like the ones would be higher up. But anyways, so then the SGLT-2s, and there's little dotted lines. So canagliflozin and empagliflozin, they have been more widely studied. Empagliflozin, if that's how you say it, I'm always struggling with that. That's on the VA formulary, and it seems to be one of the more popular ones. But if the pharmaceutical representatives from the other companies are here, that's great. Maybe your market share is going up too. Dapagliflozin and then ertugliflozin, just don't see those as often. But again, if you're selling those, that's good. And then the GLP-1s, and those have become, kind of household names. And I don't know about you, but if I get on social media, if I break my promise to myself not to look at social media, then there are all these companies who want to market GLP-1s to me, and there's a million ways to get it, and I can pay once a month, and I fill out I don't even have to really talk to my provider. It's just like someone for 2 seconds, and then I get this sent to me. So some of the older ones, liraglutide, semaglutide sort of is one of the very popular ones, dulaglutide, but they're all popular. And then the other ones we don't hear about. So the first one, semaglutide, is the injectable, but then in the second list, there's also an oral semaglutide. That's why it's on there twice. There's 2 different brand names, one for the injectable, one for the oral. And then same thing for exenatide. And okay, so now we're thinking about Angus again. So we know he was recently diagnosed. His diagnosis A1C was 8.5. His BMI was 35. And he worked for 3 months on lifestyle modification, and he was able to lose 5% weight loss, just kind of on his own with lifestyle modification. So then we think about, okay, what are we gonna start him on? And I'll tell you that when I first started, it was a sulfonylurea, because that's like all we had. So everyone got sulfonylureas. That is not the answer anymore in terms of the evidence base. So we'll talk about what's going to help us make the decision about which drug would be best to start Angus on. I'm not sure why. There we go. So there's a really long table that I put at the end of the slides because it has 18 different boxes. Really, it weighs down to, do they have other comorbidities? And that really drives your initial decision making. So I am going to go right to the shorter version of that, which is thinking about comorbidities and benefit. And this is a much condensed version of the diabetes algorithm. So if we're thinking, should someone start immediately on an SGLT2? Should they start immediately on a GLP-1? Or is metformin still okay? And by the way, it's generic and it's cheap. My residents, a year ago, I was precepting the residents, and a patient had come in and she was on long-acting insulin in the hospital because she was sick, and she was newly diagnosed and she had no insurance. And they're like, and we're going to send her home on a long-acting insulin and an SGLT2. And I'm like, what are you guys, crazy? Do you know how much those cost? This lady has no insurance. She hasn't had a chance to fail lifestyle modification and metformin. Maybe it might be reasonable for her for 3 months to do lifestyle modification and metformin and see how things go for her. That will only cost her $4 a month instead of a crazy amount of money. So obviously it has to be individualized. So people who don't have these specific disease comorbidities might be okay to start on metformin, and that's still sort of like the evidence-based direction. or if other things weigh into it. Both drugs, I call them the 1s and the 2s because it's just easier to say that, right? Both the 1s and the 2s have shown some positive benefit in atherosclerotic cardiovascular disease. So kind of throughout the body, any type of cardiovascular disease, cerebrovascular disease, they both have shown benefit. SGLT2 has had more evidence initially on heart failure, initially with low ejection fraction, but then a little bit more evidence on regular and preserved ejection fraction. Chronic kidney disease, there's a benefit for both. Obviously, for overweight or obesity, there's a definite benefit for the GLP-1s. And so the studies have shown that if that's the patient's only comorbidity, then that might really drive you, and the patient might really want to take a GLP-1 because they are very, very popular. So we're going to start Angus on a GLP-1 because he's obese and he has none of the other comorbidities. Sounds like a good idea for him. He tried some lifestyle modifications. So when did these come around? They've actually been around for 20 years now. They seem new, right? But they're newly the rage. But the first one was approved in 2005, and then the newest GLP-1 was approved about 8 years ago. And so a good nickname to call them is the tides, that they all end in the word tide. And I like to, when I see a generic name of a drug, I immediately try to think, what class of drugs is this in by the name of the drug? So the tides would be GLP-1s. How do they work? They work in the pancreas. They increase this glucose-dependent insulin secretion and basically decrease gastric emptying and increase satiety. So through hormonal changes, they slow the transit down through the gut and they make people feel more full. So people sort of, not naturally, but pharmacologically have a decreased appetite and a decreased caloric consumption. So that's how they work. So I think it's important to know, how do they work? Because it helps us think about side effects and who may or may not be the right patient for these drugs. So what are the benefits? I kind of touched on them already a little bit. Some of the newer drugs have a little bit more evidence, but just thinking as a class, the benefits have shown decreased mortality, so that's a good benefit. Decreased MACE, which is major adverse cardiac events, so nice for potential cardiac disease. Earlier stuff was showing less on the kidney front than the SGLT2s, but I think more recently there's been more evidence about kidney disease. And then weight loss, we all know about that one. And then thinking about the mechanism, what kind of side effects would we expect? The speaker this morning who was talking about opioids and constipation and GLP-1s, actually people can get either. You would think that everyone would have constipation on a GLP-1, but no, some people actually do have diarrhea. And certainly nausea and vomiting because they're holding stuff longer in their stomach. A great side effect can be decreased appetite, unless it's an elderly person who already has muscle wasting and maybe that's not the right drug for them. And then some people can build up a tolerance to the effects of the drugs. And some sort of hacks or tips for GLP-1s. Always want to start with a low dose, especially if a patient's been on it and had an interruption in therapy. If they go back to that higher dose after being off for a couple of weeks, they could have a lot of GI side effects. So if for some reason they're off for a month or two, they want to go back to the initial dose and then work their way back up. And you want to keep about 4 to 6 weeks in between dose increases. For some people, it's helpful if they do that. If you have decreased gastric emptying, eat smaller, eat more frequently, and try to reduce the fat content to decrease some of those GI side effects. For some people these drugs don't cause hypoglycemia, but if the patient is on something else that causes hypoglycemia, they may need that downward adjustment. So some people may need less insulin if they were already on insulin. And then we want to just kind of look at creatinine. And then if someone's having a lot of nausea, vomiting, and diarrhea, we think about electrolytes. So now here's the slide. So the indication for diabetes is there. The indication for obesity is there. And there are more and more studies coming out to show that, like, obesity and heart disease or sleep apnea, there's more and more things that are coming out kind of over time. But in general, the brand name determines which FDA indication it has, and also what's going to be paid for under what cost. And we'll talk a little bit. Oh, that's at the bottom there. So off-label use, word of mouth has it that people are doing things to get people to qualify for the insurance preferred brand, such as having them take a glucose tolerance test, but instructing them to skew the results. So here, take 2 glucose loads and get your blood drawn immediately. Things like that. So we can, it's interesting because most of the time patients don't want a diagnosis on their chart that they don't have, but in this case, people do want the diagnosis, so their insurance will pay for this medication. So there's also, some of that kind of off-label use, more using it for obesity in people who don't actually, who don't actually have diabetes, but trying somehow to get it approved. And the studies or the benefits in obesity without diabetes, those are ongoing. And that's why I said, there's some newer evidence that talk about sleep apnea and reduction of risk of sleep apnea. So there are more and more things that are coming out that I didn't add in here. Then the insurance company gets more and more complicated all the time. So in March of 2024, a Medicare Part D coverage of semaglutide for patients with obesity and known cardiovascular disease was approved. However, in April of 2025, a new memo came out that said Medicare Advantage won't cover any GLP-1s for anything but diabetes. And so it's sort of a moving target. There are some company health plans who were covering GLP-1s in 2024, and they tend to really increase drug spend and cost. And so some of them have taken those out of their insurance formularies in 2025. So all I can say is it's a rapidly evolving situation and no good guidance on whether or not it would be covered generally for the diabetes indication, but less so for the obesity and the other indications that have followed. So it makes it a little bit more difficult. We have this handout, which maybe if you have an online thing of all the slides and everything, I sent copies of this. It's also on our website, MICIS, M-I-C-I-S, maine.org. And I love this handout because it kind of puts everything in one place. And when I work at the hospital, it's always on a weekend at night. And so like at midnight, I'll be like, oh, I remember one of those side effects. I need to look up and see which drug it was, the 1s or the 2s. And I'll pull up this thing and I'll be like, oh, good. Okay, this patient can take this drug and it's not a contraindication. And so I like it as a reference. So we have one for GLP-1s, and those are green because they start with G. And then the other one is red for the SGLT-2s. I couldn't think of a salmon. It was a salmon color that starts with S. Okay, so now back to Angus again. So now fast forward 5 years, he's 50. He's been taking this GLP-1 now for 4 years. And he comes to see me. And I always joke about this. He's at a critical access hospital and he's diagnosed with a non-STEMI. And they call me because I also do transfer calls on the weekends at night. And I say, thank you so much. We have no beds. We'll let you know as soon as we can get him here. But it's a weekend and it doesn't matter because nothing's happening till Monday, cath-wise anyways. So, reassure the patient that he's getting good care and give him all his meds over the weekend and we'll get him here and we'll try to get him cath Monday. Or we have this fast track thing now where people can come in the door and go right to cath but not on Mondays. And anyways, so now what are we thinking about Angus? He's been on the GLP-1, he's been doing, but now, because he came to see me on my service and I admitted him, the cardiologists want to add the SGLT2. So the SGLT2s are a little bit newer. So they started coming out in the mid-20 teens, and they're the Flozins. And I think that's nice because some people say the way you remember that is it really makes your urine flow. And so the way they work is all in the kidney, and they increase the amount of glucose going out by decreasing the amount that gets resorbed into your bloodstream. And to put it very simply, which I can remember this, it makes you pee out the sugar. and patients can understand that too. And so many of the side effects or complications of this medication have to do with the fact that it makes you pee out sugar. And so when I can link those things in my mind, I'm more likely to remember them. So what kinds of benefits do we get? Some of them have been studied on different things, but in general, another mortality decrease. So again, two great, I mean, we over like say the past 10 or 12 years, or a little bit more, we have these two new classes of drugs in diabetes after not really having a lot of new ones for many, many years. And they both decrease mortality and they both decrease major cardiac events, which the cardiologists love SGLT2s, but also they're decreasing their business. So definitely slows progression of chronic kidney disease. And we'll talk about the little bump you can see right when you start. It has a decreased hospitalization benefit and reduced ejection fraction. And like I said, as time has gone on, there's a little bit more evidence for preserved ejection fraction in that intermediate. That's the benefit in other heart failure types, but maybe not reducing hospitalization, but still a benefit. And it can lower people's blood pressure because they're having this almost like a diuresis. And so that's something to be careful of and think about, especially in our older patients. So what kind of side effects? Increased urinary frequency and volume. So people might be more thirsty, which is good generally, but they also might be getting hypovolemic, orthostatic, and can have acute kidney injury, especially if they're on the drug and something else happens. So you see that a lot. Someone's doing fine on the drug and whatever else event happens, and then boom, they go over the edge and they're also taking an ACE inhibitor and they're also taking an NSAID, and boom, they're in acute kidney injury. The infections are generally down where you pee out the sugar, right? So urinary tract and then the genital mycotic, and a rare association with Fournier's gangrene. And then a euglycemic DKA, which is kind of interesting because you might not suspect it because their glucose is only like 200 or 250, but they're actually acidotic and in DKA. And what things can kind of lead someone to having this DKA associated with the SGLT2, any acute illness. So a lot of times I think about discontinuing their SGLT2 when they come in because they're acutely ill. Surgery or colonoscopy, if you're seeing someone and they're having a colonoscopy, now the GI offices and the anesthesia places are telling people to hold both of these drugs 3 to 7 days prior to the procedure. For the ones, it's because that decreased emptying, if you're going to have an upper or lower scope, they don't want stuff to be sticking around in there. And for the twos, it's because it's increased risk for this DKA. It's completely incompatible with a keto diet, so not a good idea. Fasting, so that's something to think about. Ramadan ended a couple weeks ago, but in our patients who are fasting significantly, this might not be a good choice. If people suddenly stop taking their insulin, that can put them at risk. If they've had DKA in the past, if they're using alcohol. Type 1, me as a family doctor, I would not be giving my type 1 diabetics SGLT2s or GLP-1s unless an endocrinologist, for some good reasoning that I trusted, put them on it. I'll be like, good, that's fine. You do that. You're a subspecialist. Me, I'm kind of staying on the book. And if someone has type 1 diabetes, I am not starting these drugs on them de novo. And then a little bit more caution with the older population because they're at more risk of the side effects. I had a guy come in who was like 82, and his very well-meaning primary care person started him on an SGLT2 because it has lots of benefits like cardioprotective, renal protective. A month later, he came in with a UTI with euglycemic DKA. He didn't have acute kidney injury yet, but he was pretty sick. And I was like, oh, is this benefit in this 82-year-old really going to be helpful? Like whatever disease processes he had are already probably starting. So I talked to him and I said, I really don't think you should go back on this medicine. I think it just didn't agree with you. And it may not be worth it. And so that's for him and his regular provider to go through and try to decide. But I didn't think for him it was a successful trial because he ended up in the hospital for 5 days. Tips for SGLT2s. So people should be drinking more water, but especially older people probably should be drinking more water anyways. I know my mom's 82 and she does not drink enough water ever. And a lot of it has to do with mobility and incontinence and all that stuff. She's not even on a diuretic, but I think our older patients in general run around kind of hypovolemic just at baseline. For the SGLT2s, you definitely want to be checking electrolytes. For the ones, the electrolytes are optional. You just want to check a baseline creatinine. But for SGLT2s, definitely check the follow-up creatinine at 4 weeks, because GFR is expected to decrease. And so everyone's going to take a little initial hit, but if they take more than a 30% hit, that medicine didn't agree with them. So it's very common to see people have a 10 to 20% decline in their GFR, and that's not a reason to stop the drug. But if it's at that 30% or more decline in their GFR, then it's not the right medicine for them. So that's why that 4-week lab follow-up is really important. And then also their blood pressure, because if they get if they get orthostatic, and if they're taking a lot of other blood pressure meds, they might need a little less, because this works very much like a diuretic. And here's the little sheet in salmon red for the SGLT2s that just kind of goes through everything, the mechanism, the benefits, the contraindications, the common side effects. So the next thing is just a little bit about costs. And this is kind of the issue with everything in healthcare, right? The things that work really well, that are new and innovative and potentially beneficial, that might save us money downstream, tend to be very expensive and paid for unless you're in what is that out in California? Kaiser, unless you're in like a capitated healthcare system like the Veterans Administration, or then the benefits of paying this much money for these drugs are not realized by the insurance companies. So both very expensive. The gliptins are another class that are not used as widely. They also can be pretty expensive. The glitazones, there's only one maybe left of those, and they are cheap now, but not on the algorithm as first, second, or third line. Metformin can be first line for some people, and it's still cheap, so I like that one. And sometimes the sulfonylureas are all that you have, but they're not they're like fourth choice at this point. But for a while, they were all that we had. So I'm going to talk a little bit about hypoglycemia. What time are we done? Like 3 o'clock? I think 3 o'clock. Okay. So hypoglycemia. So now we have Angus's buddy or uncle Atticus. I thought that was another good main name. So here's Atticus. He's 67. He's had diabetes for 20 years now, and he's been on basal insulin for 2 years. He gets started on an SGLT2, and then within the first week or two, he has 2 episodes of symptomatic hypoglycemia. So the considerations for him are, when he got started on the SGLT2, maybe he needed to be monitored and decreased on his insulin. And we can think about what things might have put him at risk for hypoglycemia. So there are some things you can't change. People who've had diabetes for a long time are more likely to have these episodes. We used to call them brittle. They're just harder to control, and they have these huge swings. People who are more frail or older age, people who are cognitively impaired because maybe they're not eating correctly, if they're having chronic kidney disease and fluctuations in their volume status. So those are all non-modifiable risks. So when we're thinking about starting any new medication for diabetes, we want to think about those non-modifiable risks to decide, is this the right drug for this patient? The modifiable risks that maybe with some education you can overcome is like this irregular eating. I had a guy I had on buprenorphine who worked the night shift, and we really had to think about how and when did he take his buprenorphine doses, because it didn't work for him to take like 2 strips first thing at 8 o'clock in the morning. We had to think about like how, so same thing for people who have irregular habits, irregular schedules. The insulin and the sulfonylureas, we need to kind of watch those closely, especially in the beginning, or if there's any acute illness. And then think about what other drugs they're on. And then alcohol use comes up over and over again. So I kind of joke, I took the family medicine boards the same year I took the addiction medicine boards. And that was in 2018. I didn't know as much about addiction then, but I was like, I'm just going to take the boards. And like 50% of it was overlap. I mean, there's like, alcohol is like pervasive in primary care. And so it wasn't much of a stretch to like have the same questions about alcohol use in the addiction medicine stuff. which plug for alcohol use disorder. There are multiple medications that are evidence-based that decrease desire, craving, alcohol use, and can help people cut down or become abstinent. And they're widely underused. Amelia might be talking about that next door right now, so watch it on the video, because I want to see what Amelia had to say. So as a hospitalist, I was kind of cavalier about hypoglycemia. And I'll tell you my a moment, I don't want to say shame, my moment of learning episode where I got called down to rehab one night. It was like 10 o'clock, code stroke. And so I go running down to rehab and I walk in the door and they say, glucose 35. And I was like, score! I was so excited, right? Because it wasn't a code stroke anymore and I didn't have to go any further or think about it. I just knew that their glucose was 35. That was the wrong response for me to have because it turns out hypoglycemia increases risk of all-cause mortality, cardiovascular events, falls, which we're obsessed about in the hospital. And so it was but anyways, I got on the neurologist has to call in whenever there's a cold stroke. And I'm like, we got this, glucose 35. Thank you very much. Have a good night. Boom, hang up. But it was the wrong thing for me to think. I was pretty cavalier about hypoglycemia and we have to be really careful. You know, what's right for that patient. Sometimes 150 or 175 might be okay while they're in the hospital and we don't have to be so crazy about it. Same thing with blood pressure. We overtreat blood pressure in the hospital too. You see your patients come out of the hospital on 2 new blood pressure meds, way too much overtreatment. There's definite evidence of harm of overtreating blood pressure in the hospital. You know, and I'm like, it's because we're checking it. Stop checking it. And sometimes they'll be like, what? I'll be like, no, don't check the blood pressure again until morning. And they're like, okay, what's your name, doctor? I'm documenting this. I'm like, no, seriously, write my name down. This is how to spell it. Do not check the blood pressure again until morning. That patient's going to be okay. But it's a hard thing. It's a hard habit for us to break. I put in one slide on CGM because it's become more and more popular over time. And like I said, some patients want to have CGM, and even if they don't qualify for it, sort of based on evidence and insurance criteria, they'll pay out of pocket to get it. For some people, it can help their glucose levels. Really, it's for people who are on insulin or with significant hypoglycemic events. There's really not as much evidence to show if I have diet-controlled diabetes that I'm going to benefit from CGM as opposed to an A1C every 3 months that shows that I have good control. There's really not robust evidence for that. Like I said, some patients choose to get their own. And the nice part of it is obviously it's on your phone and you can kind of set the range of what you want to be notified about. On insulin, that's a whole nother story because it can really be helpful in terms of monitoring and looking at patterns. So on insulin, yes, absolutely good evidence indicated. People who are not on insulin, maybe not as much evidence to show that it's worth the effort and cost. But not everyone's in agreement with that, patient-wise. So I'm going to go through some comprehensive care stuff here, like last couple minutes, then we'll have time for questions. And these are all from the Veterans Administration. This was published in 2020. And the Veterans Administration has some really nice evidence-based prescribing materials. And like amazing, they're in the public domain. The last time I went to look for one of their materials, all of their stuff had been taken down and is awaiting further review. And I had a little moment of sadness because I thought they were great resources. So I hope they're able to bring them all back up soon. But I had already copied this stuff from the 2020 guide, so I still had this stuff. But I don't have if they've had an update in 2023 or 2024. So the first thing is to think about antiplatelets. And aspirin like drives me crazy, right? Because every year you hear something about aspirin. So this was a couple years ago, and it's probably changed since then. But if someone has diabetes and no cardiovascular disease, Probably even with diabetes, the risk may outweigh the benefit. So in the older days, we were starting everyone who was at risk on an aspirin. Now it's more like based on a risk calculator or other things. Now, secondary prevention, that's different. So you've already come to my wonderful hospital and been treated for an MI and got your cath on Monday and went home on Tuesday. Yes, you're going to go home on aspirin, and you're probably going to be on aspirin lifelong. And then if you got a stent, you're going to have dual antiplatelet as well. So like clopidogrel or something else. And then sometimes we don't like people on triple antiplatelet anticoagulation, but sometimes that happens too, because you also have AFib and you got a stent and you had an MI. So ugh, don't like that situation. So just to remind us to think about aspirin, but that maybe it's not necessary. All right, next one is blood pressure, and this changes every couple years. I fixed one of them, which is with diabetes. The goal at this point is 130/80 for people 60 and over. And then they have some other things. And then they talk about looking at thiazide diuretics. Now that has changed. The thiazide's not number one on the list anymore. ACEs, ARBs, SGLT-2s are on this list now too sometimes. And then just think about the benefit to kidney protection for an ACE or an ARB, but now we have kidney protection from GLP-1s and SGLT-2s. So some of this will need to be updated, but just to think about blood pressure, because blood pressure along with diabetes is something that sometimes is not optimally controlled. Next one is cholesterol. That's another thing that changes all the time. So this says for patients with diabetes who are over 40, cross the line, prescribe a statin. It doesn't even talk about LDL levels. It just said, so we really need to be thinking about, if this patient has diabetes, should they be on a statin? And then you can also look at those other scores. If they have risk factors, do they need to be on a high intensity statin? But the general line is, if they have diabetes, should they also be on a statin? And then you might say, well, no, in this situation, this patient doesn't need it. Feet, we always think about feet, right? We have people take their socks and shoes off. We do the microfilament testing. We talk to people about taking really good care of their feet and looking for wounds or injuries and not walking outside with their bare feet. I haven't done that quite yet, but I did get my flip-flops out yesterday. So just being careful of their shoe choices. Gastroparesis, and this kind of goes back to GLP-1s. If someone has documented gastroparesis, that's a contraindication to a GLP-1, because in someone whose gut is already working too slowly, we don't want to give them a drug to make it work even more slowly, because that's just asking for trouble. So for people with gastroparesis, maybe an SGLT-2 would be a better choice. And there's like a behavior modification that people can do to try to help with gastroparesis. And then there are some treatments like metoclopramide they don't have on here. There's an antibiotic that's used every now and then. It probably doesn't have as much robust recommendations. Okay, kidney disease. We think about that a lot with these two new drugs because we know they're both beneficial. So we're looking at people's kidney function. We're looking at their GFR. The pharmacists love creatinine clearance more than GFRs. They would have to explain it to me what the difference is. I know at the hospital, if I'm calling the pharmacist to ask about a medication, I'm going to tell them what the creatinine clearance is, not the GFR, because I know they want me to tell them that. But it's easy for me as a hospitalist because there's no patient who can come to my hospital who doesn't get like a comprehensive metabolic package and a CBC before they either get transferred or admitted from the emergency department. So for me, it's easy. I always have a creatinine GFR from today for that patient, and I usually have some baselines. It's a little harder in primary care because you might not be checking it quite as often, and so you don't have that right in front of you. Looking at proteinuria once a year, and then they talk about kind of the recommendations for ACEs and ARBs, but also to think about if they have documented chronic kidney disease, that they could benefit from both of these drugs, both of the newer drugs. Neuropathy, the filament testing, kind of like looking, we talked about that treatment for pain. Think about duloxetine, think about gabapentin, pregabalin. I tend to be very conservative in my opioid thinking, and there's no evidence to show that opioids are effective for the long-term treatment of diabetic neuropathy or any other neuropathy. They are widely used. You have to think about risks and benefits. If a patient's not already on them, probably a good choice not to start them. And to think about some other things that we can do. Certainly glucose control can help a little bit with neuropathy, but once it's there, but you can temper it a little bit. We already talked a lot about obesity, so we don't even need to go with that. And then the retinopathy, the dilated eye exam once a year. This is every other year for people who didn't previously have retinopathy. You know, it used to be screen all patients with diabetes once a year. Smoking, we all talk about smoking a lot and try to talk about ways to help our patients. There are drugs that can help with nicotine addiction. Some of them are more successful. And the last thing, vaccines. I'll just say it right out loud. Vaccines prevent disease. They are scientifically proven to be an excellent preventative medicine for all of our citizens. There. But for these particular... That was my soundbite for when the media comes. For patients with diabetes particularly, we want to think about pneumonia, we want to think about Hep B, the regular immunizations, and then I added in here because this was published earlier, COVID, RSV, if they qualify for that, so all, and influenza. So I think of the trifecta of respiratory viruses that many patients, like especially over the age of 60, would qualify for: a COVID vaccine, an RSV vaccine, and an influenza vaccine, plus all the other stuff. So there we go. We have a couple minutes for questions. So lifestyle management is the cornerstone. We all know that's really difficult for us sometimes and our patients. Drug therapy is a second choice, but sometimes more effective and more desired. We're thinking about comorbidities when we're picking which drugs. The two newer drugs have really excellent benefits and are also very expensive. So trying to weigh that and seeing what's available to what patient. Being careful with our A1C targets, especially older people with comorbidities, they don't need to be below 7. That's like too tightly controlled. And then thinking about our comprehensive care stuff. It's easier now that we have electronic health records. We used to have stuff on paper that like kind of reminded us of all the things we had to do for diabetes now, but sometimes health records, electronic health records, don't make our lives easier, and we lose sight of some of those things that we need to be doing. So we have time for some questions.
I have one real quick before I open it up. Do you have patients that you see in your practice who are on Jardiance for a cardiac condition? They don't have diabetes, but they do struggle with weight and obesity, and so cardio prescribes the Jardiance, but then they come to the PCP and say, can I also take Ozempic for my weight? I mean, I've seen some evidence that maybe you can use an SGLT2 with a GLP-1 under careful monitoring, but do you see that at all?
So I'll rephrase that. When we were talking about empagliflozin as a medication, I'm sort of sheltered in my life as a hospitalist who only works weekend nights, because all I do is admit people, which I love because I feel like it gives me a public health perspective of Eastern and Northern Maine of what are people doing in their practices, because I see tons of patients from tons of primary care providers, and so I get like this huge overview. So to me, that's really interesting. I never have to make that decision. What I know is it's not contraindicated to do both. I would just be really careful that someone had been on one for a while and had been stable before I added the second one. But it's not that you can't use both, and if it's approved for both, then there can be some cumulative benefits. But lucky me, I don't ever have to make that decision.
The SGLT-2s, should we use caution when we're starting them in a patient with profound hyperglycemia? Certainly a patient who has type 2 diabetes, but entry glucose is 416. Does that increase risk for genitourinary complications? If so, for what period of time?
That's a really good question. That's not in my slides. I vaguely remember something about people with super high A1Cs or super high like glucoses, that could be a little risky. And with the GLP-1s and the SGLT-2s, you don't see a huge A1C, as huge an A1C lowering benefit. And the protective, cardioprotective, renal protective things are seen almost independently of that A1C lowering. So someone's A1C might stay the same at 8, but they're still getting that kidney protection, heart protection, even though their outcome measurement hasn't changed that much. So I think that that's definitely something to be cautious about, but I don't have it written down.
Can you speak on like GLP-1s and getting a regular lipase level, or I know like in my practice, it's starting to become regular that people are starting GLP-1s and getting a lipase every 6 months after when they're getting A1Cs to ensure that there isn't some sort of pancreatitis brewing. And we've got a lot of complicated answers on whether like that should be a regular thing or it shouldn't be regular.
So when I researched this with a clinical pharmacist who does all diabetes management, this was 2 years ago. So I can tell you like when we made all these materials, which is why it's now retiring, because it's run its life of 2 years and now it's going to be put up on the shelf. There was no recommendation specifically to check lipase. The other thing I can tell you as a hospitalist is lipase levels don't correlate necessarily with pancreatitis. So if someone comes in the hospital with pancreatitis, we teach the residents not to check a lipase or an amylase again the next morning, that it's clinical. Is the patient having less pain and are they feeling better and are they getting rehydrated? But that we don't make decisions based on that level. So I don't know how helpful that is. I don't know. Certainly there's a risk of pancreatitis with these drugs. I don't know if there's evidence to say screening people is effective in kind of heading that off. I don't know. There might be an article that was published last month that I haven't read yet.
I think I can help answer that question. In the initial studies of both the semaglutide and the dulaglutide, Trulicity, they did see a slight increase in lipase and amylase levels to be given, but there was no recommendation to check them. Good to know.
It's interesting as more and more people take a new drug. Like I used to teach about what we called NOACs in 2012 and 2013, novel oral anticoagulants. Now they're not novel anymore, so now they're DOACs, direct oral anticoagulants. And what we used to teach then as the drugs were coming out was different than what we know now that millions and millions of people have taken these drugs and there's just a sort of greater body of evidence in use in the general population, because generally studies that get drugs approved can not necessarily mimic the general population. They tend to be people who had to qualify for the study. They didn't have these like pre-existing conditions that would exclude them. And then the drug gets approved and then we give them to all comers. And then we learn from that experience too. And sometimes that goes well and sometimes that doesn't go well. But now that millions and millions of people have taken these drugs, I think we probably know a little bit more now.
One more question for me, on the GLP-1 handout, it said use with caution in gastric bypass patients. What's the specific caution?
Oh, because patients with a gastric bypass by definition have gastroparesis,
That's right.
right? They have a small, like many of them have a small little stomach that doesn't empty as quickly. And that's why they have vitamin deficiencies, because the stuff, either it's emptying quickly or, I mean, the anatomy and the mechanism have changed. Even it's emptying too quickly and they're not having the same absorption, or stuff might be sticking around longer. It could be both. So I'll say both just to sound smarter.
I think they're accidentally putting music in there. I think that's what we're all just like, okay, what's that?
So thanks everyone for talking about diabetes after lunch, and turn it back to Amy.
We have 10 minutes before the next session. So I don't know if Dr. Bach's going to be here for a few minutes. If anybody has any final questions they didn't think of, but then we can head off to our next session. Thank you.